Good afternoon. Thank you for joining. And today is going to be a very interesting session on best nursing practices for hazardous drug safety. For those of you who don't know me, my name is Anna Marogna. You can see it on the slide. I am the EMEA Marketing Manager for PPE at Halyard. It is a pleasure to see so many of you joining across regions and all with a shared commitment to advancing clinical practice. Today's topic is highly relevant and deeply important, especially for those of you working in oncology and infusion settings, because we all know that these therapies are critical for patient care, but they also demand rigorous safety practices to protect those that are administering them. Today, we are very honored to be joined by our speaker, which is Seth Eisenberg, who brings over 4 decades of oncology nursing experience. His contribution to research, clinical practice, and education in hazardous drug safety have made a long-lasting impact. And we are privileged to have him with us today. Before we begin, I encourage you to stay engaged, to reflect on your own practices, and think about how today's insights can translate into meaningful improvements in your setting. If you have questions, please feel free to drop them in the chat. You should see a chat to the right-hand side. At the end of the presentation, we're going to read those questions, and we are trying to address as many as possible. And with that, I am going to hand over to Seth.
Hey, good morning. Thank you, and I appreciate that very much. I'd like to welcome you all to this program here. This is a topic that is very near and dear to my heart, but I'm going to go ahead and skip the introductions, and I am just going to go ahead and get us started here very quickly. These are the learning objectives that we're going to be covering here. We're going to discuss the health risks associated with exposure. I'm going to summarize some key points of the U.S. safe handling guidelines and compare them to some of the ones in Europe. We'll review some research on contamination and nursing practices, and then finally we'll discuss the importance and the implications of personal protective equipment, or PPE. I always like to start off with some definitions because I know in the US we call these hazardous drugs. In Europe, I know there's different definitions. In the UK, they may call them HMPs. But for the sake of this discussion today, we'll call them hazardous drugs. And they're defined by NIOSH here in the US as having any of these properties. So whether they're carcinogenicity, genotoxicity, teratogenicity, reproductive toxicities, and organ toxicities at low doses. And then the last one basically says for new drugs, if the structure is similar to existing hazardous drugs, we will classify it as hazardous as well. So let's look at the consequences of exposure. And I do this first because there are people some people that believe that these are not really dangerous and that their practices are really good, so they're not going to be exposed. So let's talk about some of the ways that nurses can be exposed. Exposure can result in certain side effects, such as those listed on the left side of this slide. Many of these are the same as what we would normally see in our patients, although the last couple down there with nasal sores and dermatitis generally are not seen in our patients. I'm more concerned about the ones on the right side of this slide, which are reproductive issues and including some learning disabilities for the offspring of women who have been exposed. And I think that's a very serious consequence. There's an irony that most of these drugs are also known carcinogens. And the irony, of course, is we are treating cancer with drugs that can cause cancer. These are some of the drugs that we know that are carcinogens or suspected carcinogens. And then on the right are a list of the cancers that have been associated with exposure to these drugs. This all occurs because of chromosomal damage. So hazardous drugs alter DNA by damaging chromosomes, and they render those cancer cells unable to reproduce. These drugs are, unfortunately, not very smart. They're not able to differentiate between a cancer cell and a normal cell. In fact, there was a 2019 meta-review of 17 studies that demonstrated that there was a significant association between hazardous drug exposure and increased chromosomal abnormalities. Now, what does that mean? It means that the study showed that the longer people handled these drugs over the course of your career, and the more drugs you handled, the higher the risk of having damage to your chromosomes. And, to be honest, we don't want our chromosomes to be damaged. This isn't really new information, though. If we go back to this rather old study from 1999, it looked at cancer mortality among nurses employed in the U.S. between 84 and 93. It found that exposed female nurses had a 30% increase in dying from leukemia, liver cancer, and an increased incidence of ovarian and breast cancer. I think this is significant. Now, you may say, well, wait a minute, this is a really old study. What does this really mean? It means this is during the time period where we were not using PPE. So I think this is important to know that this was our prime exposure period. So this is a brief genealogy of chemotherapy. We talk about the drug cyclophosphamide, which was initially born in 1958. It was the son of nitrogen mustard. It's a drug we don't see much anymore, but it was born in 49. And all of these drugs came chemically from mustard gas in World War I. This is significant because what we found from soldiers exposed to the gas in World War I is that it affected their white blood cells. And then researchers thought, well, maybe we can treat lymphoma with these drugs. And for a long time, nitrogen mustard was used for lymphoma. And we certainly use cyclophosphamide right now in CHOP regimens for lymphoma. So that's sort of where these drugs came from. Going to now take a peek at some guidelines, both in the US and international. And I want to do a little global comparison here. So I want to start off first by saying that we don't know everything in the US. I don't want anyone to think that I am here saying that, oh, we know everything and that we've got the best standards. We don't. We're still learning on this journey. And that's one of my take-home points is I want you to realize that we're all on this journey together. I do think, however, that the U.S. has been lucky in that despite having 50 individual states with different governments, the development and the implementation of our guidelines has been simpler than what I understand is going on in Europe. It's very complex over there, and I appreciate the difficulty that you are going through. In general, our nursing standards come from two professional groups, not from the government. And I think that's one of the things that has made this easier. And I'm saying this in hindsight, looking backwards, that I think it's been easier than what you are going through right now. But I'm hoping that by the end of this webinar, that you will gain some insight and some things that you might be able to do for your practices and for your local and regional governments to get your guidelines to a higher level. So I mentioned our two professional organizations. One is the United States Pharmacopoeia, USP. The second is the Oncology Nursing Society. And all nurses practicing in all 50 of our states are under this umbrella. I should also mention that the ASHP, which is our pharmacy organization, contributed greatly to the content of both USP and the ONS guidelines. So we know we owe a tremendous amount to our pharmacy colleagues. A little bit of history here, not because I like history, but because I think it's important to know that we were on a journey and you are also on a journey. So 1979 is when the first publication came out that somebody found out that there was mutagenicity in bacteria in the urine of nurses and pharmacists who handled chemotherapy. Before 79, and again, we go back to cyclophosphamide from the 1950s, we didn't know anything about these drugs. 1981 was the first article by Bruce Harrison who said, hey, we need to have some guidelines for this. And here's a terrible irony. Bruce Harrison, who authored this paper in 81, died of cancer, presumably from handling the drugs that he was handling in the pharmacy without being protected. This is a timeline of those standards. And what I want to point out is that pharmacy started out in 83. We started in 84. I started practicing in 83. So I've been through this in real time. The government here did not get involved until 86. And then the big turning point was in 2004 with NIOSH Alert and then USP 800 in 2023. Okay, we're going to go through some PPE comparisons here, and I'm not sure this slide is going to work with the webinar, but this compares some of the PPE that are differences in the different areas. So in looking at the first two are the US guidelines from USP and ONS. We have the EU 2023 guidelines. We have the New South Wales from Australia guidelines and Japan's guidelines here. But right off the bat, you can see that gowns are required for both of our guidelines. They're recommended in the EU, required in Australia, and recommended in Japan. What you see here is that gowns and gloves, gloves are required in the US, and they're also required to be double gloved in the US. And we'll talk more about that in a minute. They are recommended in the EU, and there's a certain recommendation. There's a requirement in NSW and a requirement in Japan, but those are all single gloves. Other things listed on this slide, respiratory protection is different between all these different guidelines. This is actually an excerpt from the EU guidelines, and I actually copied this and pasted this in here. And what it says is how to prime the tubing. And I'm particularly interested in the second bullet, which says fill the line partially with the hazardous solution, preventing dripping using a hydrophobic stop filter. We are prohibited from doing that. We were prohibited from doing that about 25 years ago. So we're no longer able to do that because what we found is those filters can still leak and you can drip hazardous drug when you're priming your tubing. What may be also difficult to see here, this picture is also from the European guidelines, and the nurse, or presumably a nurse whose gloves and hands we see here, those gloves are not being worn properly. So USP is a global organization, and they're designed to ensure the quality of medications. This is a pharmacy group. This is a pharmacy-based group that tells the pharmacists how to compound, but there's also a chapter in here that deals with nurses and drug administration. It's probably the first time that a pharmacy group has ever been involved in nursing guidelines. It includes content from NIOSH, ASHP, and others. And I should point out that this is actually a standard. I said guideline a second ago, but this is a standard, and it is enforced through several agencies. And I don't have time to get into the detail of enforcement, but I will tell you that these agencies have the ability to either levy a financial fine on a hospital who doesn't go by these, or they have the ability to shut the hospital down. And that's a big stick, so to speak, in terms of enforcement. Other highlights that are specific for you and I as nurses is that it provides expectations for staff education. One of my roles working at my cancer center was staff education. So I was very interested when this came out. We had to start educating our nurses about these dangers of drugs before any handling activities, because it used to be that we would give them on-the-job training. Can't do that anymore. It has to be before, and it has to be annually. It also requires we do an acknowledgement of risk. This is informed consent for nurses that this is a dangerous job occupation and that there's a danger of risk. And this risk has to be explained to all nurses who are of reproductive age, that there may be a risk of being exposed to these drugs. Our nurses are not getting this information in the universities. They learn it from us. Requires the use of a chemotherapy gown and 2 pairs of disposable chemotherapy gloves, which we'll get to, and it requires the use of a CSTD, which we'll briefly touch on later on. Okay, now we're going to talk about how that exposure occurs. These are activities that I have either experienced myself or have witnessed in various hospitals where I've consulted. I kind of put them all together, and there may be things here that you'll notice that look familiar to you. So not all exposure is the same. So we have to take into account that different drugs have different toxicities. The formulation is different if you're exposed to an IV versus exposed to a tablet or a capsule. The route is different, whether we are worried about inhaling it or skin contact. And then what are we doing? What's our activity? Are we compounding, or are we administering these drugs, or are we cleaning a spill? So as we go through some of these things, we have to remember that these are not all equal, depends upon what we're doing. We do know that dermal absorption is the primary method of exposure and absorption to these drugs. Inhalation of aerosols can also occur during compounding and vials under pressure and in spill cleaning as well. Priming IV tubing at the bedside. So the picture on the left is actually a nurse priming IV tubing, catching the drip with the roller clamp. The picture on the right is taken in my organization around 1993. This was the bottom of IV poles. We had a lot of these that were from drips from tubing. And this is with those hydrophilic filters at the end, they do drip. And this is a result of that dripping of drug and fluid on the bottom of the IV pole. We ended up replacing all of these poles when we changed over our practices. Spiking and unspiking bags and bottles have also been prohibited since the early 90s. Spiking can cause a leak in the bag. Unspiking is a little hard to see in this picture, but unspiking, you can actually see that there's droplets coming out when you pull the spike out of the bag itself. These 3 pictures are actually of a colleague that I worked with for many years. This was also taken in the 1990s. She's getting ready to give an IV push of a couple different drugs here. And you'll notice a couple things. First of all, you'll notice there's no CSTD. It's before we had them. You'll notice also that her gloves are not completely rolled up over her cuff, which it should be. But more importantly, you'll also notice that we have a blue pad or a plastic backed absorbent pad. And in the middle picture, she's got a 2x2 gauze in her gloved hand. And that's because at that point, all of our guidelines said to use a pad and gauze to catch the drips that would come off the end of the syringe, because we know that these things drip when you disconnect them. Luer lock tubing is not really designed to be completely leak-proof. It's a whole different reason why that was designed. Grabbing the spike instead of the IV bag can cause the spike to come out, resulting in a spill. This is a picture of fairly recently of one of our nurses grabbing the spike that was the CSD spike attached to the bag. And this nurse it didn't happen to this nurse, but another nurse grabbed it just like this. And when she pulled the bag out, it got caught on the edge of the Ziploc transport bag. And the CSD spike came out of it, and she had an entire bag of oxaliplatin dump all over her. Now, fortunately, she was wearing her gloves and her gown. However, there was still a big spill in the room. The drug was wasted. The patient had to get moved out while we mopped up the spill, and it delayed the treatment by about an hour and a half. So again, this is another way things can happen. Luer locks themselves can become loose. We had a big problem with nurses not completely tightening their connections. And again, as I mentioned, luer lock does not really mean lock. Luer locks were developed a little over 100 years ago by a gentleman named Herman Luer, of all things. And it was designed for insulin, not designed for chemotherapy. Puncturing the IV bag inside the transport can happen. And again, if there's leaks inside that bag, we can be exposed reaching inside that bag. Okay, so not having a CST at the end of the tubing can result in leakage when disconnecting. As you know, tubing will drip. This is the laws of hydrostatic pressure. When you move IV tubing, the fluid will always drip out of the open end. This is a picture. A nurse came to me after I did a lecture on this, and she said last week she splashed cyclophosphamide in her eye, and it still hurt. And I asked her, how did you get it in your eye? She said, well, when patients walk around with their IV poles, the tubing will oftentimes wrap around the pole. And she said the patient's infusion was done, so I disconnected him from his implanted port, but the tubing was still wrapped around the pole, so I gave it a tug. And when she gave it a tug, it flew off and got her in the eye. So again, this isn't about eye protection. This is about the fact that tubing will drip. And her colleague who was with her, who came up to me after the presentation, she said, oh yeah, I know it drips because every day I see the drops going down the hallway to the chemo disposal bin in a soiled utility room. And so we talked about the importance of CSCDs on the distal end of tubing. We'll talk more about that briefly later. Bubbles. We all have problem with air bubbles in our tubing. It doesn't matter what pump you use. There are going to be problems. And these are 2 pictures. The nurse on the left is not wearing any PPE and is pulling air bubbles and fluid out using a syringe. which is what we've all done. The nurse on the right is actually disconnected from the patient and is dripping it into a trash can to get the air bubbles out, also not wearing her PPE. Handling excreta without wearing PPE. This is also a way that we can be exposed without even thinking about it. On the right is an excerpt from a large table that I have on my website. I run a not-for-profit website, and it's listed right there at the bottom. It's www.setheisenberg.net. And amongst other things, I've got a table of every approved drug for treating cancer, both oral and IV. And these are just some of them showing you the percentage of the drug that comes out in the urine. So think about this. Think about the assistive personnel that you have with you who are possibly handling these things without having any kind of gloves or gowns on. And again, we talked about absorption being through the skin. So if you're handling urine without having gowns, without having gloves on, you're going to be exposed. You can be exposed due to CSCD failures. I love CSCDs. I've actually worked with all the manufacturers across the globe, and I'm familiar with all the devices, but they're not perfect, and they can leak due to improper use and due to defects or loose connections. Accidental disconnections, I mentioned that. And these could be patient-related disconnections. I had a patient once who the nurse told her when you need to go to the bathroom, just unplug and walk to the bathroom. Well, the patient had to go to the bathroom, and she thought unplug didn't mean the power. She thought the plug meant unplug it from her IV. So then the patient disconnected her own IV, which is a whole problem. But the pump was still going, so it was shooting IV chemo all over her chair, and it was a mess. The picture on the right may be hard to see, but that's a portable battery-operated infusion pump in the background. And the front of that gray silver, that's duct tape. The patient had a leak at home with a home infusion of 5-FU and decided to wrap up the tubing with duct tape before bringing the whole thing back into the clinic. Well, he brought it into the outpatient clinic where I worked and said, I think I have a leak. The nurse who was taking care of that didn't put on gloves, didn't have a gown, reached inside of the backpack and got contaminated with chemo. And it's really hard to see here, but the bottom of that picture in the black, you see some white specks there, and there's some white specks on the right side of that particular the duct tape. That's dried 5-FU. 5-FU will crystallize when it dries, and that's exactly what that was. There's also dangers inside bathrooms. I did a study, and I published in 2001 that we wipe tested the bathroom that the patients were using in our infusion room, and I wipe tested a staff bathroom, and I found contamination of chemotherapy in both bathrooms. We expected it to be in the patient bathroom, but we found out that our cleaners were using the same mop in the patient bathroom as they did in the staff bathroom, and they were dragging unknowingly, they were dragging the chemotherapy from the patient's bathroom into my bathroom. Other studies have reported contamination in bathrooms in the toilet rim, the seat, the flush handle, the sink, the door handle, the floor. My studies showed tremendous amounts of chemotherapy on the floor of both bathrooms. This is a consensus paper from a group that I belong to, and we actually did something called Safe to Touch conference. And the excerpt from this study was, I think, very relevant to today. And it says the importance of consistent use of the appropriate PPE for individuals involved in the handling of hazardous drugs cannot be overemphasized. This is because what was determined was that PPE is your first line of defense. This is a study published in 2025 by my colleague Anne-Marie Walton out of Duke University. And this was a review of 73 US and international studies. So I think it's important that this is not just US, this is international between 2004 and 2025. So basically 26 years of studies. It included institutions using CSCDs and those without. And the bar graph represents the number of studies reporting contamination in certain clinical areas. Maybe difficult to read, but the biggest one on the left here are floors. 40 of the studies, 40 of 73, said they had contamination on the floors. The next one, 31. This was nursing countertops. Now, how do drugs get on the countertops? Something to think about in your practice. So I think it's important to realize that this is not an old problem. This is still an ongoing problem. And it's not a North American problem. It's a worldwide global problem. So think about your practices. Would you practice differently if you were hanging a bag of Ebola and not a bag of chemotherapy? Because sometimes I've talked to nurses who are saying, oh, it's just a little bit of chemo, so I'm not worried about it. We should be worried about it. Okay, we're going to move on now and talk about safety equipment, talk on CSTDs and both personal protective equipment. We're going to start off with PPE first, though, here. So we'll talk about gloves and gowns both. We should be wearing these when handling bags, bottles, syringes, administering drugs, disconnecting containers and tubing, disposing of the equipment, cleaning spills, and as I mentioned, handling excreta. NIOSH has PPE guidelines based on formulation, and I'm not expecting you to be focused too heavily on this rather busy table here. But I think the point I want to make is that the same PPE is going to be your PPE is going to be different whether you're handling an intact tablet, which says nope, just single gloves and no gown, versus at the bottom handling IV, IM, or sub-Q, yes, double gloves and yes, protective gown. So I want you to realize that you don't always need the same PPE for every activity. It depends upon the formulation of the drug. We should be wearing our PPE regardless of where. This is 3 studies I think are really relevant. They're all international studies. A 2024 Japanese study on caring for pediatric cancer patients getting infusions at home reported that 73% of the caregivers, basically the parents and grandparents, had cyclophosphamide in their urine. Now, wait a minute. We should never have chemotherapy in our urine unless we're being treated. A 2023 French study on healthcare workers in 12 medical centers, including inpatient and outpatient, showed that over half of the personnel, over half of the nurses, had hazardous drugs in their urine. Again, we should not have this in our urine. And then a 2015 Canadian study, this is a landmark study by Han and colleagues, showed that detectable levels of hazardous drug in the urine of 201 hospital workers on an oncology unit, with 55% of the unit clerks testing positive. Now let's pause for a second here. These are unit clerks, unit secretaries. I want to ask you, how do you think these unit secretaries had chemotherapy in their urine? They were not delivering the drugs. They were not administering the drugs. They were not emptying the urine. They were at the desk answering the phone and working on the computers. The answer is, it's from us, the nurses. We brought that contamination from our patients' rooms to the desk, and then we touched the keyboards. We answered the phone, and we either didn't wash our hands thoroughly or we still had our PPE on at the time, and we transferred it from point to point to point. I cannot overemphasize how important it is to not only wear our PPE, but also to take it off at the right times and wash our hands. Okay, let's talk about the components. Gown, gloves, chemotherapy gloves, face and eye protection for risk of splashing, and respiratory protection under certain conditions. Gowns. So in the US, the guidelines say they have to be disposable. You cannot reuse a gown. They have to be tested against hazardous drugs. The gloves have to have long sleeves and elastic cuffs. Sorry, the gowns have to have long sleeves and elastic cuffs because it needs to make a tight connection at your wrist area. Closed in the front without any snaps or buttons, and they have to be single use. They cannot be removed once, they cannot be reused once they're removed. Now, I know this is a big source of controversy, but I want to ask a question. If you were taking care of a patient with COVID, or with MRSA or C. diff, and you had an isolation gown on, would you want to take that gown and hang it up on a hook or the back of your chair and put it back on throughout the day? The answer is probably not. You wouldn't do that because you don't want to risk contaminating your environment or contaminating yourself when you put the gown on. The same thing is true with gowns, which is why in the US they are disposable and single use. Single use basically doesn't mean single patient. It does mean single use. Once I take it off, I cannot re-don it. Gloves, 2 pairs of long cuffed chemotherapy gloves tested to this ASTM standard, which I'll talk more about in a couple of slides. One of the gloves goes under the gown cuff, one goes over the gown, making what I call a glove sandwich. This is a picture of one of my former colleagues, and I put the big red X there because I don't want you to do what she did here. This is a picture of her wearing her, and if you look at her left arm, that glove is not pulled up, covering the elastic sleeve, making a tight sandwich. It's loose, it's curled up there, and it's improper. Now, the question always is why 2 pairs of gloves? Why do I have to do that? Here are the answers. Number 1, to avoid contaminating the inside of your arm when you remove it. A lot of nurses can't get the gloves off well because their hands sweat, and so they will reach in and pull it off this way, contaminating the arm. The second is it allows you to connect your patient to your IV tubing, then you remove the outer glove and you can then program your pump. Did you know that pumps are one of the highest areas of contamination in the entire patient care area? We know this from wipe testing studies because nurses will touch the pumps to turn it on or program the rate while their gloves are still on. So this allows you to do it and you're still protected at least. US, we have a doffing sequence for how to take it off. This is a poster I did with a colleague, and it shows you how to basically take the gloves off one at a time, remove your gown from the front, roll it up so it doesn't get contaminated all over your clothing, and then you go ahead and take that last inner glove off. This is an excerpt, and I don't want to be accused of picking on guidelines, but I do tend to look for guidelines and scrutinize them. This is from the New South Wales out of Australia guidelines. Again, it says removing PPE for wearing 1 pair of gloves. Shouldn't be wearing 1 pair of gloves. It says remove the gloves. Perform hand hygiene with soap and water. That's great. We'll talk more about that. And then remove the gown. The problem is if you're removing your gown after having taken off your only pair of glove, then you're likely to get your hands contaminated with touching your gown somewhere, either the front, the back, pulling it off. If you have to pull it off and roll it up, how do you do that with bare hands? If there's something on the glove, you have to assume that there may be something on the glove. Not all gloves are equal. So they must be tested at the ASTM D6978 standard. This is a box. This is the side of a box of gloves I found in a supply room in a hospital where I was consulting. And I noticed that the last 2 drugs here, if you look at it on the right side, it says breakthrough detection time, not for use with carmustine and not for use with Thiotapa. And I asked the nurse who was giving me a tour, I said, do you guys give these drugs? She said, yeah, all the time we do that. I said, did you know that the gloves that you are using say don't use it for these drugs? And she had no idea because as a nurse, we oftentimes have these gloves in a glove dispenser. So the box gets put in there, it's stocked by someone. You don't see the cardboard box, you just pull the glove out. I used to, years ago, never thought about how good my gloves were. I assumed that whoever was buying these gloves knew that they needed to be tested for the drugs I was administering. That's not always the case. So ASTM requires testing with 9 drugs. Go back to your practice. If you administer more than 9, then you need to make sure you are protected against all the drugs that you are giving. This is a slide, a table I put together with 4 different brands of gloves for a list of drugs. If you'll notice, brand D compared to brand A, they're not the same in terms of breakthrough minutes. And you may say, well, I'm not going to be handling it for very long. I don't need to. You never know what's going to happen. And supposing you have a spill, spills take more than 1.16 minutes. If you look at brand C down there. So you want to make sure that your gloves are protecting you. Okay, we're going to move on now to closed system transfer devices. CSCDs, of course, are designed to restrict liquid or vapor from escaping into the environment. They provide a dry surface upon disconnecting. When I say disconnect, I mean disconnecting the CSCDs. There are more than 25 studies that have demonstrated their ability to reduce or eliminate contamination. I think these are great. I love CSCDs. I also look at CSCDs as part of the safety package. It's not just one thing we use for safety. We use safety in layers. In our cars that we drive, we have airbags that are built into cars. We also have seat belts because it's a package. It's a layer of safety. We need both of them. These are examples of some of the CSTD systems out here, and some of these are available in Europe, I know. I've worked with all these companies, and I've given drugs through these CSTDs, so I know them quite well, and they're all good systems. However, they're not 100% perfect. And these are just a sampling of studies that have been done, wipe test studies that have shown contamination of chemotherapy in hospitals and clinics, even when using CSTDs, because there are multiple ways that we can have exposure. So if you're using a CSTD and you think, well, I don't need to use gowns because I've got a CSTD, that's not completely accurate because there's still a risk of exposure. So the road to hazardous drug safety has not been very straight for us in the US. It's been long and curvy. And as my kids would say, are we there yet? No, we're not there yet. We still don't have 100% compliance of our nurses. We still have practices that are not very good in small rural hospitals and some of the private practices. You go into the small communities and they're just not as up to date on the standards as the big academic medical centers. So this is indeed still a journey. And I want you to know that you are on a journey in Europe. I was recently in Switzerland. I'll talk about that in a second here. But this is actually a paper published by a nurse that works in Switzerland, lives in Germany. And he was my host when I was in Switzerland doing some lectures there. And this is something he published it just in 2025. It was a study of German nurses, and 33% of the 400 nurses reported at least one symptom of exposure. And wait for it, only 60% used chemotherapy gloves. This is not 1998. This is not 1983. This is 2025. So regardless of where you practice, we need to remember that not everyone is practicing at the same level, and some countries have a lot of work to do to get their nurses to be using the right equipment and to be using it 100% of the time, not 60% of the time. So I'm going to close up in a couple minutes here and leave time for questions. I think we've got a lot of things going on in the chat, which is great. So I'm directing this to number one. If there are nursing administrators on this webinar, I want to ask some questions. Is your education program robust? Meaning, are you teaching everything that is required? Are your policies specific? Because a policy that's vague, nurses, we're very creative. If we see a gray zone, we'll say, well, does it really mean that? Or does it mean this? And I used to write all my policies for my organization, and I thought they were very clear. And I'd have my nurses come up to me and say, well, do you really mean this? Or do you mean this? Or I'm still okay to do it this way, right? It's like, no. They said, well, you didn't say that in the policy. So are your policies specific? And are you promoting best practice? Is it part of your culture of safety? Safety has to start with administration and educators first to work its way down to the nurses, the bedside. So for the bedside nurses, for staff nurses, do you follow your guidelines and policies? Do you read them? Do you know what's in them? Or do you work by memory? Or do you go by what? Well, my friend over here says I just do it this way. So that's what I follow her. Check your policies. And do you promote a zero tolerance approach at the bedside? We had a nurse years ago who refused to wear her gown. She was an older nurse. She was actually a little bit older than I was at the time. And she said, I'm not having babies anymore. I don't need to wear a gown. And the staff said, you know, what you're doing is making you vulnerable to being exposed and vulnerable in your work environment. And if you keep doing this, we're not going to go and answer your call lights when your patient's pump is beeping. They applied pressure on her. And nursing administration finally said to her, if you're not going to follow our policies, then maybe you need to be working somewhere else. And they terminated her. So again, we need to be having a zero tolerance approach, because what goes on in a patient's room or an infusion chair doesn't stay there. You might walk in after somebody else who didn't practice very well, and you could be at risk based on what she or he did if they left chemotherapy traces behind. So it's not just about one person, it's about all of us.